So the topic of lecture is endodontics, anatomy of pulp chamber and root canals of teeth, endodontic instruments, basic endodontic procedures such as a tooth cavity disclosure, amputation, extirpation of the pulp, methods of medicament and instrumental treatment of root canals, step back, crown down techniques, antiseptics, mistakes and complications that can develop during canal treatment. Lecture outlines such questions: endodontics is definition, clinical and anatomical structure of teeth cavities and root canal of teeth, endodontic instruments, basic endodontic procedures, methods of medicament and instrumental treatment of root canals, antiseptic solutions and ways of their delivery, mistakes and complications in root canal treatment. So what is endodontics? Actually, this is a term derived from Greek language, and it means something, the study about what is inside. So endodontics, it is the branch of dentistry dealing with the normal anatomy, cause, diagnosis, prevention, and treatment of diseases of the dental pulp, usually by removal of the nerve and other tissue of the pulp cavity and its replacement with suitable filling material. The goal of endodontic therapy is to relieve pain, control infection, and preserve the tooth so that it may function normally during mastication. Endodontic treatment is normally preferred to extraction, and therefore the main task of endodontic treatment is to cure toothache due to inflammatory lesions in the pulp, such as pulpitis, and the periapical tissue, such as apical periodontitis. Right now we move to the question of the shape of pulp cavities and configuration of pulp canals. So the dentist's knowledge of normal pulp shape, size and depth beneath the enamel is important for proper teeth treatment. When dentist determines that the tooth should have endodontic treatment, he should have appropriate knowledge of the shape of the pulp chamber and canals in particular. So on this diagram, you can see the of pulp chamber root canals. Every tooth has pulp chamber and root canals. Pulp chamber has such anatomical parts as roof of the pulp chamber, pulp horn, it is the highest points that is usually located under every cusp, floor of the pulp chamber, root canal orifices. Orifices, it is entrances to root canals here as well, and root canal with its main canal and accessory lateral canals. And here you have the apical part of the root canal. Actually, the crown part is the widest. When I say crown part, it means the crown part of the root canal. The crown part of the root canal is wide and adjacent directly to the root canal orifices. Then goes a middle part of the root canal and apical part of the root canal. Lateral canals, that is the branches of the main canal, and occur in 70–30% of cases. In endodontology, the great importance plays anatomy of apical part of the root canal, and here are defined such anatomical structures as apical foramen and apical constriction. So apical foramen or anatomical apical hole, it is the place of transition dentine into cement. And physiological apical hole or apical constriction, it is the border between pulp and periodontium, and it is usually placed 1 millimeter or 0.5 millimeter away from anatomical apical hole. Actually, physiological apical constriction plays a significant role when it goes about working length determination. So working length is defined as the distance from a predetermined coronal reference point. Usually it is the incisal edge of incisors or cusp tip in posterior teeth to the point at what cleaning and shaping and finally root canal obturation should stop. So this point is apical constriction of physiological apical hole, and all treatment procedures actually should stop here if it goes about pulpitis. And necessary to keep in mind that every material is toxic to some extent and shouldn't be pushed out from the root apex in order to prevent inflammation of periradicular tissues. So we have such methods of establishing working lengths, and they are as follows. Use of tables data of the average root canal lengths, X-ray method, and electronic apex locators. Of course, the most efficient and the most exact method is usage of electronic apex locators. So right now we are on anatomy of teeth. So anatomy of maxillary teeth. Central and lateral incisors. Usually, so why we are here? Because the anatomy of the teeth plays a great role in establishing appropriate access to the root canal orifices. That's why this knowledge of anatomical shape is essential for dentists. So central incisors usually have one, normally in 100% they have one root and one root canal. Here you have the outline shape of the access preparation in the such proximal view as well, you can see, and in these dashed lines, in this way should be done penetration of enamel and gaining access to the root canal. Canine as well has one root, big root, and one large root canal. Pay attention to the excess opening. It is ovoid in canine and triangular in anterior and incisors. So basically triangular access is typical for incisors, but if a patient is old due to aging of the pulp chamber, the outline form becomes ovoid. First premolar. This tooth has two root in majority of cases. Here you have this 57% of cases and two root canals, but as well it can have one root and as a result such possible types of canal localization. It can be a single one root with two root canals that have two separate openings, one root that have two root canals with a single opening, and one root with one root canal. And here you have the representation of cases. Generally, the shape of excess preparation is ovoid, as in this case. Excess is done from the occlusal cavity. Second premolar. This is the tooth that have one root in 88% of cases, and here you have in 11% of cases it can be two roots. So if the tooth have one root, it possibly could have one root canal, two root canals with a single opening, or two root canals with two separate openings. Here you have the representations in percentages of every possible anatomy of this root. Present, the canal orifices are located under the buccal and lingual cusps, in equal distance from the line drawn through the center of the chamber in the medial to distal direction. So under every cusp there is usually a pulp horn, and under every pulp horn there is orifice. So necessary to keep this in mind and use it, this information. First molar. First molar of maxilla has 3 roots. Their names are palatal and 2 buccal. One is mesial, one is distal. So mesio-buccal, mesio-distal. Pay attention to the excess preparation and localization of root canal orifices. 3 root canals, 3 roots and 3 root canals. In such cases, 40% of cases, it is such anatomy, and in 60% of cases, there could be extra canal, so-called MB2 canal, mesio-buccal, second lateral canal in the mesio-buccal root. And it is located a little bit distally toward the palatal side of the tooth. Outline form is triangular, but can be as well rectangular. Access is done from the occlusal surface. Second molar of maxilla. 3 roots, 3 root canals. Pay attention to the localization of roots. They are not so standing wide as in the first molar. Names of roots are the same: palatal, mesio-buccal, buccal mesial, buccal distal. And orifices of the root canals are located in such a way. In majority of cases, 3 roots separated. And as well, in this second molar, in the mesio-buccal root, can be second MB2 canal that is located toward the palatal surface of the tooth. Excess opening similar triangular or rhomboid rectangular. Mandibular teeth. So central and lateral incisors. Here you have that central and lateral incisors are considered to be the smallest teeth in all human dentition, and usually they have normally they have one root in 100% of cases, but there could be varieties in root canals. So central incisor could have in 25% of cases 2 root canals, and lateral incisor in 30% of cases as well could have 2 root canals. They can be 2 root canals with a single opening and 2 root canal with 2 separate openings. And here you have this percentage of cases. For central incisors, it is 5, and for lateral incisors, it is 15% of cases. Outline shape of excess preparation is triangular in young patients, but due to aging and decrease in the pulp chamber size, the excess opening turns to be ovoid. Canine has long, wide root canal with a single root canal in 70% of cases, but still in 20% of cases it could have 2 root canals with a single opening and 2 root canals with 2 separate openings. But these cases are of very small, 20% of cases and 10% of cases. The outline form is ovoid. Premolars. Premolars have mandibular premolars have 1 root and 1 root canal in 70% of cases, but as well possible 2 root canals in this 4% of cases with a single opening, and such shape as well possible, because sometimes it would have 2 roots that are fused on the all lengths, but only have 2 separate apical parts, separated apical parts, or it can be 2 normally formed roots for mandibular premolars. That's why these tools tends to be unpredictable if it goes about endodontic treatment. That's why preoperative X-ray is always necessary when it goes about endodontic treatment of teeth. And actually this X-ray will give the dentist understanding of what is the anatomy of this tooth and how to behave with this particular tooth. So mandibular second premolar normally have one root and one root canal in 97% of cases. The outline shape is ovoid. But pay attention to these peculiarities of this tooth. Two root canals that ends in one opening, and or one root canal that are divided only in the apical part on two root canals, and two single openings. Mandibular molars. Both first and second, they have similar anatomic configuration. However, there are subtle differences. The most common mandibular first molar configuration is two canals in the mesial root. Also, there have been reported one canal in the distal. So two root canals in the mesial root and one root canal in the distal root. But sometimes in the distal root can be extra canal. So in this way, these tools have 4 canals, as in this case, you can see. But this is typical in 30% of cases. The outline access form is rectangular, or resembles rectangular shape. Pay attention to the localization of root canal orifices. They are standing on a quite long distance from each other in comparison to the maxillary molars. And actually this gray depression, it is the floor of the pulp chamber. This is that place where pulp tissue laid down. Here you have. So the same second molar, similar, two roots. In the mesial root there is two root canals, buccal mesial, distal, lingual mesial, and in a distal, excuse me, I was wrong. So distal, mesial buccal, mesial lingual. In this way, we call this root canals, and in the distal root canal, possibly a second extra canal, but the incidence of occurrence of such extra canal is low, but nevertheless necessary to keep in mind such possibility. The shape and number of root canals in any one root have been divided into 4 major anatomic configurations or types. So this diagram shows you these types of root canal configuration. So the type 1, one canal that has the one single opening. Type 2, two separate root canals that has single opening. Two separated root canals with a two separate openings, and one canal that divides apically into two root canals, and has 2 openings as a result. So such possible 4 types of root canal configuration in one root. Successfully, we move to endodontic instruments. So new instrument systems are produced and new preparation techniques evolve. So the morphology of the root canal space is highly variable. That is why single unique preparation technique cannot be applied to every situation. Thus, more useful to develop and understand basic concepts of root canal preparation. And these can be implemented to master the diversity of root canal systems with which the dentist may be faced. This approach also allows the clinician to modify his or her current technique as new instruments are produced. All endodontic instruments are classified according to ISO standardization. So they are as follows. Hand instruments, in particular files, K and IH files, BAP broaches, spreader and plugger, vertical and lateral gutta percha condensers, rotary instruments, H files, K reamers, for slope hand pieces, lentulo spiral filler or rotary paste filler. They fit in hand pieces. Rotary instruments such as a Gates-Glidden and piezo reamer drills, separate group of instruments for enlargement of root canal orifices, and pins such as gutta percha or silver pins. But despite of this international standard organization classification, in clinical practice, it is proposed to use classification by Courson that were proposed in 1996, and it is based on the clinical usage of endodontic instruments. So according to this classification, all instruments are divided on diagnostic instruments. It means root needles, in example, Miller needles, Pathfinder, instruments for removing the soft tissue such as a barbed broaches, instruments for passing, enlargement and shaping of the root canals, K-reamers, K-files, H-files, instruments for obturation such as lentulo spiral filler, vertical and lateral gutta percha condensers. And now, one by one, propose to look on these instruments and try to understand their function and peculiarities of use. So let's start from the rotary instruments, and actually Gates-Glidden drills is the first instrument. Here you have this instrument, here you have its magnifying working end. It looks like a small drop with a sharp blades. This instrument is used to cut and enlarge root canal orifices and thus facilitate placement of hand endodontic instruments. Different sizes of this instrument are available. There is a color coding on the handle of this instrument, like a color bands on it. So it is slightly flexible and will follow the canal, but easily can perforate canal if used too deeply. Should be used only in straight sections of the canal. Piezo reamer drills. This instrument is used for retreatment procedures to remove gutta percha from the root canal orifices. It is a small flame-shaped cutting instrument. Pay attention, it's magnifying working end. As well, different sizes available with the color coding on the handle. Piezo reamers are not flexible. If not used with care, can perforate root canal. NITI, nickel titanium rotary instruments as well, they are available as hand instruments. Mainly all instruments are manufactured from stainless steel, but they are not flexible and usually tends to fracture. That's why such nickel titanium NITI instruments were developed. They are flexible enough, that's why they can easily follow the shape of the root canal. And In this way, fracture is not so typical. Fracture of instrument is not so typical. Here you have the rotary instruments. As well, you see color coding on the handles, and it is hand instrument, niti. Pay attention to its geometrical symbol. It is rectangular, square, but it is divided on two parts. One is black and one is white. So here it is his geometric symbol of niti files. They are used to clean and shape canals. This used with endodontic handpiece. And hand instruments is obvious, it's hand instrument. Niti is flexible and follow the canal outline very well. Several varieties of systems with different sequence of instruments are used. Important to follow the manufacturer's recommended speeds and instructions for use if it goes about rotary niti instruments. Another instrument that fixed into handpiece, slow speed handpiece, it is lentulo spiral filler or rotary paste filler. As well, pay attention to these colored rings. These colored rings means the size of instruments. Function of lentulo to introduce obturative material into root canal space. It fits into conventional handpiece, necessary to use with caution as it can be easily broken inside the root canal if it is used not carefully, and different sizes available. So right now we are on hand endodontic instruments, and let's start from the barbed brooches. So the functions of barbed brooches to remove the pulp tissue. Here they are, different sizes available. Here it is the magnifying working end. You see here it is small hooks, and actually this hooks is responsible for catching the pulp tissue and retracting it. So pulp extirpation normally is done with barbed brooch. In this case, barbed brooch is inserted into the root canal to the 2/3 of the root canal length, and then rotation should be done. Few rotary movements should be done in order to catch the pulp tissue. And then, if there is a feeling that pulp tissue is caught, necessary to do retraction and remove the pulp tissue from the root canal. K-reamer, K-file, H-file, hand endodontic instruments that are used for root canal passing, reamer in particular. K-file is used for enlargement of the space of the root canal, and H-file is used to shape the root canal, removing all irregularities of the wall that possibly develop on the previous stages of using K-reamer and K-file. According to International Standard Organization, all instruments have their unique geometric symbols, geometric coding, and for reamer it is triangular, for K-file it is square, for K-flex of file it is rhomboid, H-file it is circle. Colored coding of the handles of the instruments indicates the dentist of the size of this instrument. Here you have the scale of the most typical sizes of endodontic instruments, starting from the 6 and ends with a 40 size. Actually, what does it mean, this size? It means the tip, the diameter of the tip of the instrument. That means that this instrument with the size 6 has a diameter tip 0.06 millimeters. And one more important information about endodontic instruments, it is their taper. Taper increases for 0.02 millimeters on every millimeter instrument gain in length. So that is the taper of the instrument, 0.02. It's typical common taper of instruments. So on this diagram, you see different commodification instruments: K-flexophile, K-file, K-reamer. So K-flexophile, they were introduced lately in 1980s. For opposite, K-file has its history from the beginning of the 20th century. So almost 100 years they are in use. So K-flexophile is similar to K-file, but made by twisting a rhomboid-shaped blank, alternating blades with acute and obtuse angles. It is more flexible than K-file, but becomes blunt more quickly. Pay attention to this spiral. Twisting a rhomboid blank. As a result of it, such shape of K-flexophile develops. K-file has in a cross-section triangular, and it is made from stainless steel wire, which is twisted to make this file. This instrument is not flexible, that's why it is susceptible to fracture if it is used with pressure. And about the structure of this instrument one more. So there is approximately twice the number of spirals on the file than on the reamer of a corresponding size. Pay attention. So in general file, it is tight spiral with a blunt tip. Here as well, blunt tip. Reamer. In general, reamer, it is loose spiral. Pay attention. Compare this one and this one. So reamers made from triangular blank, number of flutes, this is the flutes, so blades this, 1/2 to 1 per every millimeter. Reamers have less number of flutes per millimeter than files, but they are more fracture resistant than files, and actually this is characteristic of reamer. It has sharp ending, that's why this instrument is aggressive and can cause perforation if it is used without caution. Every instrument has its special motion. The cutting action of instruments can be done in either a filing, rasping, or reaming, drilling motion. In a reaming motion, such is done penetration, rotation, and retraction. The file tends to set in a dentine more readily than the reamer and must therefore be treated more cautiously, because in a reaming, K-file and K-reamer can normally work. That's why if it goes about reaming action for file, necessary to be careful in order that K-file easily catch dentine than reamer due to its tight spiral. Withdrawing the file cuts away the engaged dentine. In such a situation, instrument can be rotated 1/2 turn before retracting. Here you have penetration, 1/2 rotation, and retraction. In a filing motion, usually works H-file and K-file. The instrument is placed into the canal at the desired length. Pressure is exerted against the canal wall, and while this pressure is maintained, the rake of fluids rasps the wall as the instrument is retracted without rotation. So just pull motion, pressing to the wall of the root canal, and only in this way the debridement is done. So K-reamer, K-file works in reaming, H-file, K-file works in filing. Pay attention, K-file can work both in reaming and filing motion. But filing motion is very efficient done with headstrom files. Headstrom files only work in filing motion. There is it is prohibited actually to do rotation with headstrom file because it can lead to fracture of this instrument inside the root canal, and thus endodontic treatment is compromised. Together with filing and reaming action, a few more possible motion available in the root canal. So combination of these two. So we have reaming and filing at the same time. It's combination of reaming and filing. Push instrument to the working length and then rotate one half and pull it back. Such possible motion. Then watch winding motion. Watch winding motion is less aggressive than quarter turn and pull motion, as this one. That is a combination of reaming and filing, because in this motion the instrument tip is not forced into the apical area with each motion, thereby reducing the frequency of instrumental errors. The technique watch winding motion is effective with cut-type instruments, files and reamers. So watch winding, left and right, pressing to the wall and then retraction. Watch winding and pull motion. Insert file, then rotate it 30-60 degrees to the right and to the left, and then pull it out. This is the most commonly used method, especially with H files. So now about instruments. K-reamers. Nowadays, reamers are rarely used or indicated. They were replaced by files, but nevertheless, manufacturer produced them and they are available. So disadvantages of reamers include their inflexibility with increase of size, which can result in a wider canal being cut apically. Here you have these K-reamers. Color coding, you see, and pay attention to the loose spiral. So reamers cut by being tightly inserted into root canal, twisted clockwise 1/4 to 1/2 turn to engage their blades into the dentine, and then withdrawn. In general, it is such: penetration, rotation, retraction. The cut is made during retraction. The process is then repeated, penetrating deeper and deeper into the canal when working length is reached. The next size of instrument should be used, and so on. Files. Again, should stress your attention that K-files work both in filing and reaming motion. But the file has no need to contact all walls simultaneously. Wall can be passed by the file in a turn. For example, the entire length and circumference of large diameter canals can be filed by inserting the instrument to the desired working distance and filing circumferentially around all of the walls. Here you have these files with geometric symbol on the handle of the instrument and color coding of the instrument. Headstrom files. Headstrom file more aggressive than K file and must never be used with a rotary action, as they are apt to fracture. All endodontic instruments are available in disposable containers such as this, because they are sharp instruments, so they should be distributed in such containers in order to prevent either injury of the dentist or the fracture of the instrument. So flutes of the headstone file resemble successfully set triangles one on another, or it resembles a screw-type instrument. Positive rake angle, hence it's effective in the direction of instrument removing, so only it works in retraction. It is not flexible and easy to be fractured, hence they are used only in a straight portion of the root canal. Here you have the geometric symbol of the headstone file. It is circle and number of its size, and at the same time handle of red color indicates that it is size 25. So here I have put what does it mean taper. So for every millimeter gained in length, the taper of instrument increase for 0.02 millimeters. And here you have the working length of the instrument. It is average length for all endodontic hand instruments, 16 millimeters. Working length, it is part of an instrument that are in contact with tooth substance, and general length of the instrument. Here you have general length. Instruments are available in a standard length, 25 millimeters. Commonly used long, 33-28 millimeters. Such instruments can be used in this for these tools that are located distally. And access is hard to them, and short instruments, 21 millimeters, is used in that cases when opening of the mouth is limited, and patient can normally open mouth. That's why dentists cannot use standard lengths, standard long instrument. Pro-taper files. Their variable taper and advanced flute design offer efficiency to achieve consistent shaping even in calcified canals. Here you have the pro-tapers. They have such sizes. So with these 6 instruments can normally be treated all root canals. So only one instrument sequence, whatever the canal shape. They are color-coded and easy to follow protocol of treatment. It is necessary only use of 3 instruments for most of all cases. Because of the great taper, they can faster and efficiently clean and shape root canal. Apical taper for good canal cleaning, and great debris removal due to the unique multiple taper design of these instruments. So right now, these instruments is available on endodontic market and has great usage. Common terms and expressions that are used in endodontics are tooth cavity disclosure, pulpotomy or pulp amputation, pulpectomy or pulp extirpation. So tooth cavity disclosure, it is removal of pulp chamber roof, thus facilitating access to root canal orifices. Pulpotomy is done under local anesthesia, and it is surgical removal of the inflamed coronal pulp with the subsequent medical processing of its root part by imposing of therapeutic liner and a permanent filling. And pulpectomy or pulp extirpation, it is a treatment procedure by which the entire pulp tissue previously anesthetized is surgically removed and replaced with a root filling. So technique of pulp amputation. The essential first step is anesthetizing, then preparation of carious cavity, then unroofing of the pulp chamber and gaining access to root canal orifices. This is done with a round burr slow speed handpiece, and on the stage of unroofing, Pulp amputation is done with the same burr for slow speed handpiece. In a case if there is a bleeding, should be applied hemostatic liquids on a cotton balls to the root canal orifices and antiseptic liquids to clean from any debris that occur on the stages of pulp amputation. And after cotton ball with antiseptic or hemostatic liquid is removed, tooth cavity should be dried, and above the remnants of the pulp tissue should be placed calcium hydroxide material. Above it should be placed a cotton ball and then temporary dressing with a dentine paste or water dentine. And we should wait that these teeth should stay vital, hopefully, due to this treatment procedure. Calcium hydroxide dressing is left in the caries in the tooth cavity for 14-21 days, and it's considered to be enough for formation of dentine bridges for calcification. So that is a sufficient period of time in this case of pulp amputation. Pulp extirpation has such stages. Tooth cavity is previously disclosed, then strine access to root canal orifices is obtained, and after, the barbed broach is inserted into the root canal to 2/3 lengths of the root canal. Rotation should be done and pulled together with the pulp. In general, it is 1-2 rotations to catch the pulp tissue. For successful manipulation with barbed broaches should be observed such recommendations: to work with instrument only in a straight part of the root canal, not to push instrument inside the canal deeper than 2/3 of its length, not to force instrument into the canal, and do not use barbed broaches in canals with visible obliterations on X-ray, as it can lead to fracture of the instrument. Of course, it is mistake that will influence the endodontic treatment adversely. So we have such main purpose of root canal treatment: removal of pulp, removal of infected dentine from the inner wall of the root canal, and enlargement and shaping of a root canal for its adequate filling. Stages of root canal treatment as follow: disclosure of the tooth cavity, disclosure of the root canal orifices, the root canal passing, the root canal enlargement, the root canal shaping. Disclosure of the tooth cavity technique. So, first of all, it is necessary to establish an outline form, and then initial penetration into enamel should be done with a high-speed handpiece. If it goes about anterior group of teeth, penetration is done perpendicular to the tooth surface, and then turn the handpiece toward the long axis of the tooth, following the way of the root canal, and in this way would be gained access to root canal orifices. This turn is done in order to prevent perforation of the fascial surface of the tooth crown. In posterior group of teeth, access opening is done from the occlusal surface in a certain shape that this tooth should have, either rectangular or triangular or trapezoid. It depends from the tooth, but steps are the same. At first, initial access preparation of enamel is done with a high-speed burr, and then should be turned to slow-speed burr. Basic steps in tooth cavity disclosure. So preparation of enamel and dentine, then penetration and unroofing that is achieved by Fischer high-speed burr or slow-speed handpiece, and Fischer burr or round-shaped burr. Then location of canal orifices and identifying by pass finder or small endodontic instrument the root canal to its full length. And then with a Gates-Glidden burrs or piezo-largo burrs to cut this bulk of enamel, this bulk of dentine that is located above root canal orifices in order to make this straight wall and to connect caries cavity and tooth cavity into one cavity for later better vision of the root canal orifices. Access preparation, actually, it is the most important phase of root canal treatment, and the bulk of procedural errors and treatment difficulties are related to errors or problems in obtaining adequate access. Sometimes dentists try to preserve to structure as much as possible and don't remove this part of dentine above the root canal orifices, and thus location of root canal is of problem, and necessary to remember that the greatest amount of microorganisms and bacteria stay in this area of root canal orifices. So if root canal orifices is appropriately shaped, enlarged, at the same time we have good access to root canal orifices and removal of microorganisms from the tooth cavity and not pushing them into root canal area, and that is the main goal of root canal orifices. So disclosure of the root canal orifices, it is a necessary condition for full disclosure of the tooth cavity and in the stage of creating access to root canals. So for this reason, enlargement of the root canal orifices is done with a spherical burr of small sizes or specialized burr, Gates-Glidden or piezo-largo. Advantages of orifice enlargement effectively decrease the curvature in the coronal part of the root canal, allowing straighter access for files to the apical region, like on this diagram with dashed lines, is show how should be done, how the dentine should be cut. As well, orifices enlargement reduces the probability of apical extrusion of infected material, as most of the canal debris is removed before apical instrumentation takes place. And this is particularly important because the majority of bacteria of an infected root canal are located in the coronal region. And here, this picture shows you ideally shaped tooth cavity with gaining straight line access to all root canal orifices. The tooth cavity is properly disclosed when it completely connected with the caries cavity. Their walls pass into each other without irregularities, forming a straight line, and final shape of cavity should be such that all canal orifices can be easily located with small K file or other endodontic instrument. Here I have prepared for you examples of access openings that were done on extracted teeth. So in maxillary incisors, triangular, in canine ovoid, as well ovoid in premolar with clearly visible two root canals. Here you have clearly visible access to 3 root canals and the floor of the pulp chamber. So outline form is triangle. In a case if this molar is 4 canal molar, so such access opening is done. Always necessary to keep in mind that possibly can be presence of extramolar in mesial-buccal root. Anterior mandibular teeth, canine such ovoid as well, and molar of mandibula, 3 root canals, wide root canal in a distal root, here you have, and in a mesial-buccal, mesial-lingual, and such for canaled molar of mandibula. In a distal root there are 2 canals. Pay attention to the shape of this cavity, rectangular. So that is the ideal access opening. And now we are on instrumental treatment of root canal, the next step after root canal enlargement of root canal orifices goes instrumental treatment of root canal. And actually it is debridement of the root canal space, and it includes removal of vital and necrotic tissue, bacteria, bacterial byproducts, and dentinal debris that were created during the cleaning and shaping process. Cleaning refers to the debridement of the root canal space, shaping at the step to prepare the canal for obturation. All clinically accepted endodontic instruments and instrumentation techniques attempt to perform both processes simultaneously. The instrumental treatment of root canal is done using hand endodontic instruments in sequence: K-reamer, K-file, and H-file. For these purposes, root canal passing, root canal enlargement, and root canal shaping. Manipulations of root canal treatment are carried out manually or with the help of rotary instruments by several treatment methods, and the most widespread among them are apical crown, crown apical, and hybrid method. Apical crown method means that treatment starts from the apical part of the root canal, moving to the coronal part of the root canal. Coronal apical means opposite from root canal treatment starts from the crown part of the root canal, moving downward. And combined or hybrid method means that root canal treatment starts at the crown apical technique, and at the middle of the root it is stopped and reversed to the crown apical part of the root canal as the crown apical part, the crown apical technique, excuse me. So this is the hybrid method. Step back technique refers to apical crown methods. So in general, the apical part of the root canal is prepared first, and the canal is then flared from apex to crown. During this treatment technique, the blockage of canals can occur and irrigation can be difficult. Such steps of step-back technique we have. After coronal pre-enlargement with Gates-Glidenbers, here you have the smallest size of instrument is placed to the apical foramen, and actually this apical part of the root canal is shaped with master apical file. Actually, master apical file, it is that instrument that is used to prepare apical portion of the root canal, and it is the last instrument to prepare it, and it won't be enlarged anymore. So it is master apical file. Then bigger sizes of instruments are taken in sequence, K file, H file, until the canal get its final funnel cone shape. Here you have some ledges on the root canal wall, but these ledges at the final stage is shaped with the H file, because H file is responsible for shaping irregularities of the root canal wall. During step-back technique, recapitulation with a small K file is done on every stage to smooth canal and to ensure that the canal is not blocked. Recapitulation means that after every instrument of bigger size should be taken size smaller and then bigger again. And actually this is done to remove irregularities on the canal walls. Of course, any instrumental technique should be accompanied with antiseptic washing of the root canal, because it's an essential part of instrumental and medicament treatment of root canal. Irrigation and instrumentation should go hand by hand. The step-back technique has such advantages: less periapical trauma, more debris removal, increased condensation to the pressure. Disadvantages: extrusion of debris, apical blockage, tendency of canal deviation. Crown down technique. This is the most favorite technique if it goes about rotary instrumentation of the root canal. Such steps it have: enlargement of root canal orifice, it is initial step, then taking the biggest size of the file and starting preparation of the root canal from the coronal part to the apical part of the root canal, changing instruments in sequence, K file, H file, in order to clean and shape the root canal. Recapitulation is essential as well, because it prevents from irregularities on the walls and blockage of debris. And of course, irrigation should be done after every instrument is inserted into root canal, because antiseptics not only kills microorganisms but also facilitates easier placement of instrument into root canal. And finally, the root canal should have such cone shape with equal walls without any ledges on them. And this can be obtained by using headstone files. Biological benefits of crown down technique: removal of tissue debris, less post-operative sensitivity as it is a pressureless technique, hence there is no extrusion of debris into the periodontal ligament. Better irrigation as coronal obstructions are removed, better tissue dissolution as the irrigation is improved, rapid removal of contaminated tissues, and now we are on balance force technique. So this involves using blunt tipped files with an anti-clockwise rotation whilst applying an apically directed force. It requires practice to master, but is particularly useful when preparing an apical part of severely curved canals. So actually this technique is advocated for severely curved canals. In this technique, instrument is inserted inside the root canal and to the working length, and then rotated clockwise 90 degrees with a light pressure to engage dentine. Then file is rotated counterclockwise 120 degrees while apical pressure is maintained to cut and enlarge the canal. Debris is removed with the final clockwise direction and retraction. So this is technique basically used for curved root canals with a specialized flexible files. So irrigation and instrumentation, it is that techniques that essential part of root canal treatment. And during the procedure of root canal treatment, irrigants are routinely used. In cases of chronic infections, intracanal antiseptics are applied to achieve optimal disinfection. Intracanal medicaments are basically antiseptic agents applied to canal walls to prevent bacterial recolonization. For the disinfection of root canal, suppression of post-operative pain by reducing inflammation, and for the facilitation of periapical healing. And that's why a knowledge of the various intracanal antiseptics is important to choose the antiseptic for a certain case. So here you have reasons why antiseptics are used: to kill bacteria after chemomechanical instrumentation, to reduce inflammation of the periapical tissues, to dissolve remaining organic material, and counteract coronal microleakage. As well, antiseptics in endodontics has a great and long history. The first antiseptic that were introduced is sodium hypochlorite, and it's almost 100 years of its usage in dentistry, in endodontology, and actually it's effective. So such key facts of irrigants I propose here. First of all, irrigants are required to flush out debris and lubricate instruments. Dilute sodium hypochlorite is generally considered to be the best irrigant, as it is bactericidal and dissolves organic debris. It's a key fact. The normal concentration is usually 2.5 available Fluorine, but it is available in less and more concentrations. Chelating agents which soften dentine by their demineralizing action are particularly helpful when trying to negotiate sclerosed or blocked canals. It is recommended to coat instrument in antiseptic solution every time it is inserted into root canal, because irrigants not only cleans the root canal but also dissolves flakes of debris on the working part of instrument. Irrigation does not completely debride the canal. Sodium hypochlorite will not remove tissue from areas that are not touched by files. It's important to stress. In fact, no techniques appear able to completely clean the root canal space, and even after irrigation with antiseptics, still some amount of microorganism is left inside the root canal. The root canal is never sterile to the end. Frequent irrigation is necessary to flush and remove the debris generated by mechanical action of the instruments. So it is key facts that I propose to keep in mind, try to analyze and remember them. Irrigants can be delivered in such a way. First of all, by using endodontic needle and syringe, and by coating instrument in antiseptic solution every time it is inserted into root canal. Here you have this endodontic needle with specialized, specially designed tip of the needle. It has opening on a lateral border, and actually this design prevents direct extrusion of the antiseptic into periapical tissues, and thus prevents toxical influence to periapical tissues, because all antiseptics, it is water solutions of acids, and acids, it is toxical substances that can cause burning. So a needle should be inserted only to the one set of the root canal lengths. Basically, it should be placed to root canal orifices, and then press on the syringe and start irrigation. Be sure that needle is free inside the root canal. If it is blocked, washing is not done. That's why antiseptic treatment won't be done appropriately. Actually, it will split into oral cavity. For better placement of endodontic needle into the tooth cavity, it is recommended to bend it in such a way. Of course, operative field should be protected by rubber dam or cotton rolls in order to prevent leakage of antiseptic, because antiseptic, it is acid, as I told, and acids lead to burning of mucosa, for example, or periapical tissues. So that's why mucosa should be protected, and try not to push antiseptic into periapical tissues. For that reason, apical stop, apical constriction should be shaped according to requirements. As such, medicaments are available. They are grouped as follows: phenolics, eugenol, parachlorphenol, aldehydes, formocresol, halides, sodium hypochlorite, sodium hypochlorite, steroids, calcium hydroxide, antibiotics, and combination of different groups of medicaments. So sodium hypochlorite, it is material, it is liquid that has a great history for almost 1 century. Yes, it's true. Due to its toxicity, the extrusion through periapical hole should be avoided. The irrigating needle must be placed loosely in the canal. Insertion to binding and slight withdrawal minimizes the potential for possible extrusion of sodium hypochlorite in periradicular tissues. And special care should be exercised when irrigating a canal with an open apex. Actually, if there is such case when root canal has open apex, better to replace hypochlorite by some another medicament that is not so toxic. Actually, not recommended in the treatment of apical periodontitis, but this sodium hypochlorite is very good and effective in the treatment of pulpitis because it has ability to dissolve organic debris. Chlorhexidine. Chlorhexidine, it is antiseptic that is used not only for mouth washing but also as intracanal medicament. It possesses a broad spectrum of antimicrobial activity, provides a sustained action, and has a little toxicity. So it is stated that 2% of chlorhexidine has similar antimicrobial action as 5.25% of sodium hypochlorite and is more effective against Enterococcus faecalis. But chlorhexidine has no ability to dissolve necrotic tissue and to remove the smear layer from the root canal. Important to note that sodium hypochlorite and chlorhexidine cannot be used simultaneously for antiseptics of the same root canal because they influence one another adversely. As a result of chemical reaction of this co-interaction with one another, flakes occur and blockage of root canal can appear. Thus, endodontic treatment of root canal is compromised. Despite of this, it is recommended if such necessity is present to use sodium hypochlorite and chlorhexidine for the same root canal. It is recommended and it is actually indicated to wash root canal with distillated water after sodium hypochlorite and after that put chlorhexidine. Here you have this chlorhexidine solution. Dicamfen, it is a brand name. It is a combination of corticosteroids that possesses bacteriostatic action. Solution is effective in disinfecting root canal of a tooth during endodontic treatment, in particular in the case of pulp, necrosis, and gangrene. Parachlorphenol, it is active ingredient of the medicament and it is bactericidal component. It is more effective than phenol. That's why it is included in this combination. It denaturates protein, could cause burn to the skin and the mucous membranes. Thymol, that is a component of solution, has bactericidal effect, and dexamethasone, non-steroid anti-inflammatory drug, provides anti-inflammatory and anti-allergic effect. Another component of the solution is camphor. It has a buffering function towards parachlorphenol, namely camphor should prevent the penetration of excessive quantities of the active substance in the tissue or in an interstitial fluid. It also guarantees long-lasting effect of medicament treatment. So such material, dicamfen hema, once again, Indication is for pulp necrosis and gangrene. Formocresol, company Hema, antiseptic solution for the treatment of inflammation of dental pulp in temporary molars by vital amputation method, as well as inflammation of the dental pulp of permanent molars that has incompletely formed roots. Solution has bactericidal and mummifying action, and it is his benefit. It can mummify pulp tissue due to the presence of formocresol in its combination. But formocresol as active substance considered to be cancerogenic, and it is recommended to avoid usage of this material. Nowadays it is prohibited to use in USA due to this cancerogenic action on the organism. Without these decalcifying agents, it is impossible to treat sclerosed and obliterated root canals. Decalcifying agents such as a Canal Plus, company Septodont, or root canal enlarger ETA is used in especially narrow and sclerosed root canals, and that they facilitate easy passing and shaping of these canals. Some quantity of this material is left for few minutes in the root canal, or it is placed to the root canal orifices, and then the active ingredient of this material dissolves calcifying tissues, and as a result, easy manipulation within this root canal. Drugs for chemical enlargement of root canals are grouped in this way. Solution of ETA, such representative as Largal Ultra Septodont and the Friedenkia, a solution of citric acid and propionic acid, for example, Verifix company SPAD, gels that are based on ethylenediamine tetraacetic acid are Canal Plus Septodont, RC Prep Premier. Prepared root canal for sealing, regardless of the method of instrumental treatment, must fulfill the following criteria. It should be sufficiently enlarged. It should have tapering shape, conical shape. It should have appropriately formed apical constriction. Do not contain any necrotic dentine. Do not have typical smell of pus if it goes about pulp gangrena treatment. It should be clean and dry, and should not have any painful reaction to percussion, once again, if it goes about periapical inflammation. So if such criteria is present, these tooth can be successfully filled, obturated with a final root canal, material for root canal obturation. So we have moved to errors and mistakes that can develop during endodontic treatment. Of course, successful endodontic therapy depends on many factors, and one of the imperative steps in the endodontic treatment is canal preparation. To clean and shape the root canal system efficiently is the main task of the doctor. Unfortunately, procedural accidents happen during endodontic treatment, such as instrument fracture, overfill, underfill, ledge formation, or perforation, and external transportation. Main problems occur during preparation of curved canals. Here you have grouped common errors in canal preparation. Basically, they fall in these categories: preoperative, intraoperative, postoperative. So preoperative, it is misdiagnosing. Yes, of course, a correct diagnosis is important for development of appropriate treatment plan. That's why collection of anamnesis of patient's disease, doing of all necessary main and extra examination would prevent from misdiagnosing. Intraoperative, such as incomplete debridement, instrument fracture, apical transportation, hypochlorite accidents, ledge formation, apical perforation, lateral perforation. To avoid these intraoperative errors, dentists should first of all provide appropriate access opening for root canal treatment, have good vision of operative field, if possible use endodontic microscope to magnify, and be careful when it goes about instrumentation of the root canal. Remember that instruments are able to be fractured. That's why should know how to work with every instrument appropriately. When it goes about hypochlorite accidents, necessary to protect operative field by rubber dam or cotton rolls, cause hypochlorite acids and can cause burning. And this burning can lead to necrosis of mucosa. So this is necessary to keep in mind. And in general, to avoid any mistakes, necessary to know how to do everything correctly and be careful with everything what you are doing. And post-operative errors such as pain and infection. In a case if there is a post-operative pain, possibly there was left some parts of necrotic dentine, or infection were forced through the apical hole due to inappropriate instrumentation of the root canal, and reinfection occur. So all of this should be kept in mind. These errors should be kept in mind in order to prevent them. But it is just few of them are placed here. Of course, if to think more, we can find few more possible mistakes and complications. For example, propose to your attention this diagram. Here you have the curved root canal, and hard stiff instrument is passing through this canal. It is not flexible, that's why it can tend to ledge formation, in this case zipping, or even in this case perforation can be done by, in this curved root canal, by non-flexible hand endodontic instrument. In conclusion, successful root canal treatment is based on establishing an accurate diagnosis and developing an appropriate treatment plan, applying knowledge of tooth anatomy and morphology of the root canals, performing the debridement, disinfection, and obturation of the entire root canal system. And finally, such statement. There are no secrets to effective root canal preparation, just practice, patience, and persistence. So try to use this statement and such references that were used for this lecture. You can as well go deep into these books. Endodontics, Principles and Practice, Mahmoud Torabinejad. Anatomy, Wolfel's Dental Anatomy is a good book that gives not only the anatomical structures, but also some main treatment techniques. You can look in this book, it's a good one. And Textbook of Endodontology presents a clinical cases, and Clinical Endodontics as well, useful book. So all of them has the right to be used for study when it goes about endodontology. So thank you for attention and good day to you. Good luck.